An intimate journey to the edge of life.
Nobody wants to die. And nobody wants to die badly.
Into the heart of modern medicine.
There's almost always something else that we can do to put off the inevitable.
Where patients, families, and doctors face the hardest decisions.
If you're tired and you don't want us to do this anymore, that's okay with me.
The moments of hope.
People surprise us all the time. Patients that we didn't think could breathe do breathe.
Patients with severe illness will go with you to the edge.
The will to fight.
We'll make it through this. Have to.
Why give up? What's that gonna do?
And the courage to let go.
I think doing nothing is a very important consideration. It really depends on what you want.
If there's one thing absolutely certain in life, is that life does come to an end. Put simply, we're all going to have to face death at some point in our lives. Even with the most sophisticated and advanced life-saving medical technology, there are instances where death is inevitable. Some of us will die in ways out of our control, and most of us will be unaware of the moment of death itself. Still, death and dying can be approached in a healthy way. So today we take you through an intimate journey into the edge of life. We're focusing on death and dying. Our special expert panel today includes the Executive Director of the Resuscitation Council of South Africa, a palliative care doctor, an ICU nurse, a palliative care home care nurse, and another palliative care social worker from Wits Hospice. So sit back, relax, and learn from this show ahead. Interact with us on our Facebook page, SABC Health Talk, and on Twitter at SABC Health Talk. I'm Dr. Sello Mutaung, and this is Health Talk.
If there exists one experience that throughout history and around the world binds mankind together, it is death. Death is something we all must face. When it strikes, no exercise or diet regimen, no meditation techniques, no amount of money can reverse it. It is the great equalizer. The finality of death coupled with the uncertainty of an afterlife results in fear for many.
I'm petrified because anything could happen at any time and you wouldn't exactly know like what's going to happen after that, who's going to take care of your family, what's going to happen with you as a whole. Yeah, so it's a scary topic.
Not everyone, however, faces death with fear and uncertainty.
I can't say I'm scared of dying, but because why everybody's still gonna die. I have that in mind, I'm still gonna die. Although whatever, I'm trying not to be scared, but I know I'm still gonna die. What can I say? It's just to say I know that I can only put my trust in God.
People don't really necessarily have to die because God has given us eternal life. So the world will be a paradise. So for them, they just have to carry on with their lives.
We take it for granted that most people have a birth plan for their offspring, but few discuss or make arrangements for their own eventual death. This might seem like a morbid topic, but many people have specific wishes about their end-of-life care or what they would like to happen to them after their death. However, a reluctance to discuss these issues makes it much less likely that these wishes will be met.
Yeah, so I've spoken about it with my mom. She's all casual about it, but yeah, obviously arrangements will have to be made and life goes on after that.
I don't want to be buried. I want to be burned and my ashes to be like thrown away to the river or something.
I want to die happy. I don't want to die having any regrets or any things that I felt like I needed to do in my life.
Families, relatives, caregivers, health professionals, and patients should support each other to have dignity around the time of death. People only get one chance to have their end-of-life wishes met. This is why it is vital to talk, plan, and make arrangements for the end of life before it is too late. Talk about your wishes and the practical arrangements that could be put in place in advance of a crisis. Families, relatives, caregivers, health professionals, and patients often find it difficult to talk about the subject of death and dying. Being able to facilitate such conversations well and in a way that is sensitive to everybody's wishes is a real skill.
We could do everything to get you back home, but then what might happen is the bleeding might start again, because we're not really doing anything to definitively fix that bleeding, because we really just can't anymore.
Right.
There are 5 simple steps you can take to make your end-of-life experience peaceful, both for yourself and for your loved ones. Plan your future frail care and support. Consider registering as an organ donor. Tell your loved ones your wishes. Write your will. Record your funeral wishes. Every minute someone dies, but many people still feel uncomfortable talking about end-of-life issues. Talking about dying, death, and bereavement is in everyone's interests, as it can help ensure that at the end of our lives, all of us can get the care and support we want and where we want it.
To help us understand more about death, we welcome our special guest, Professor Walter Kluk. Professor Kluk is an Executive Director of the Resuscitation Council of South Africa and is based at the Emergency Medicine Department at West University. Welcome to Health Talk, Prof.
Thank you. Good morning.
All right, and next to Prof, we have Dr. Mike Brown, who's a palliative care doctor based at the Wits Hospice. Welcome to Health Talk, Dr. Brown.
Thank you. Good morning.
Right. Prof, let's start with, well, from the basics. Let's try and understand what this death is. You know, I mean, this is, I was just saying off air with you just now that it's a very difficult, sometimes emotive subject to talk about.
Absolutely.
Sometimes regarded as taboo, because some people believe that if you talk about death, you actually are inviting death. But as I said in my intro, I mean, this is something inevitable, isn't it? So what is death?
Death is where the heart stops beating, the patient stops breathing.
Simple as that?
Simple as that. The heart either stops or it may quiver slightly. It's a condition we call ventricular fibrillation.
Yeah.
But the person stops breathing and the heart stops beating effectively. So you get insufficient blood going to the heart and to the brain.
Mm-hmm. Okay. Now, perhaps let's start by, defining what, or at least describing what you do as the Resuscitation Council. I mean, obviously, the bulk of this show is often dedicated to promoting a healthy lifestyle so that we prevent people dying prematurely. And I would imagine you resuscitate people back into life. Just tell us a little bit about what you do.
Absolutely. The Resuscitation Council of Southern Africa offers training courses. We have over 1,000 instructors, over 100 training centers around the country that offer regular courses to train people on CPR, to try and prevent death and unnecessary death.
Okay.
And it's really the public need to know how to do CPR. It's a very simple procedure.
Yeah.
You compress on the chest and blow in the mouth. You can prevent death by getting the circulation going.
Right.
Get blood to go back to the heart, go back to the brain.
Okay.
And it's a very simple technique that anyone can learn.
All right.
It's
if
all
we have a
based
bit
on
of time, we will come back. We may ask you to just go a little deeper into how actually people can do that. But talking about death, who actually is at risk of dying?
Well, there are different causes. There's trauma and there's non-trauma causes. Certain causes are end of life, where people have got chronic illness. And there are other causes that are sudden, unexpected death. And these are things like heart attack, choking, drowning, electrocution, which are sudden, unexpected. And those are the tragic ones, where time is crucial.
Right.
And if you can get help fast, you can actually save the person in the unexpected death.
All right. Perhaps let's introduce Dr. Brown. Dr. Brown, you involved in palliative care, I would imagine, on the other spectrum that the Prof just described now. Tell us a little bit about what you do as palliative care. What is palliative care?
Well, palliative care really is largely focused on end-of-life care. Right. The word palliative care comes from the Latin pallium, which means a cloak. And so in palliative care, we cloak the patient and the conditions that the patient is facing and provide a holistic approach to accepting that the death is inevitable, but managing that process for the patient and for their families so that it is as comfortable a process and as well controlled a process as possible.
Okay. The Prof mentioned, acute unexpected death, from trauma and that sort of thing. But from your experience now, at the other end of the spectrum, as it were, what are the kind of conditions that lead to death that you're familiar with?
Well, mostly in the hospice where I work, the patients have some form of cancer. So probably the majority, 85% or more of our patients, have been diagnosed with a life-threatening cancer which hasn't responded favorably to treatment, and who are now facing the end stage of life as a consequence of progressive cancer disease. Mm-hmm. We also have patients who have heart failure, which is, I suppose, the oncology of cardiology, because heart failure, where it's unable to be treated, ultimately will also lead to death. Mm-hmm. Renal failure, where the kidneys have failed, liver disease, and ultimately liver failure. Mm-hmm. So those are some of the other conditions that we might be facing. At our facility in Soweto, we have a larger proportion of patients who are suffering the consequences of end stage of HIV infection, of AIDS. And so that's another factor that we deal with in terms of end-of-life care.
Okay. We're going to talk a lot more about hospices and palliative care in a bit more detail. I just wanted us to lay the ground for discussion, going forward. Now, there are signs and symptoms. I would imagine in acute death, it's very simple. But in impending death, are there signs and symptoms that anyone can notice, Prof?
Absolutely. So in a hospital environment, even pre-hospital, watch the person's breathing.
Right.
So breathing rate suddenly increases or suddenly decreases. And in fact, if a person stops breathing, or sometimes they just gasp, it could be a sign of death, where they're lying and motionless and suddenly take a slight breath. And that could actually indicate that the pulse has stopped and there's no output. So that's the really scary part. The level of consciousness decreases as the patient gets worse, and the pulse disappears. Obviously in the hospital setting, one would check the pulse and the heart rate.
Yeah.
Pre-hospital, we don't recommend that the public check for a pulse, because if you're anxious and you see someone getting worse, your pulse beats rapidly, and you can always feel a pulse if your heart is beating, which you think is the patient's pulse.
Yeah.
So we recommend looking for breathing, either no breathing or slight, what we call gasping. And there you need to get help immediately, because time is crucial.
Yeah.
Once the heart stops beating and there's no circulation to the brain, you get brain death.
Yeah.
And you've only got 3 to 5 minutes to get back up, to start some CPR, to get an ambulance, to get professional help. It's very time sensitive.
Dr. Mark Brown, from your perspective, are there physical changes that people go through that you can see that perhaps may indicate to people like you that death is near?
Yes, you must remember that in hospice and in palliative care medicine, the vast majority of our patients are managed at home, in their own homes. Probably 90% of our patients are managed and die in their own homes. Some die in hospital, the remainder die in our inpatient unit, where we have 9 or 10, 11 beds for patients. And in those situations, we're expecting death. It's not the sort of sudden situation that the Prof is referring to. So we would see patients generally becoming weaker over a period of time, more frail, and the families expect this because we advise them. The level of consciousness, of awareness, of interaction becomes less. Their interest in activities around them, their interest in eating, their interest in taking any fluids, all of that diminishes. And gradually we'll see the patients becoming weak, pale, circulation starts failing, blood pressure starts dropping, respiration changes. We often see a pattern which we refer to as Cheyne-Stokes breathing, where there are periods of apnea followed by periods of more rapid breathing, and then they stop breathing for a time period, and ultimately they take the final breath. So that's quite common and the sort of pattern that we would see on a more frequent basis.
Yeah. I suppose it's not a pleasant aspect of medicine, I would imagine, for any professional. But we'll come back to that. We just need to go for a quick commercial break. After the break, we'll learn more about artificial life prolongation. Please stay with us. Now, we're going to find out a little more about artificial life prolongation. But before that, let me introduce another special guest who's just joined us. And this is Sister Buhle Mokoena. Now, Sister Mokoena is from the ICU and High Care Center, Bone Marrow Center based at the Garden City Clinic in Johannesburg. Welcome to Health Talk, Sister Mokoena.
Thank you.
Did I say it correct?
Yes, it is.
All right, okay. But perhaps before we talk about artificial life prolongation, tell us a little bit about what you do at that center.
It's very interesting what we do in the unit that I work with. We get to see a lot of patients that have been acute diagnosed with the cancer. What happens is this is where the unit that they'll be getting chemotherapy. And I must say, in the hospital that I'm working at, we are so privileged because with the latest technology and the multidisciplinary team that we've got there, most of our patients, they really make it. You know, it's such an honor to work there because you are there all the steps throughout.
So these are patients that are, for lack of a better way of putting it, on the verge of dying, and you actually observe them making a turnabout.
Okay. They are not on the verge of dying.
Yeah.
Because I've seen a whole lot of patients that when they come in, you know, they've been diagnosed, and some of the family members or the patient themselves, they don't even believe that they are going to make it. But hence I've said that with the treatment, you know, and once you get diagnosed and you start the treatment, the possibilities of making it and be on remission, as we call it, you can go up to 5 years, 10 years, 15, up to 20 years. I mean, we've seen patients that took chemotherapy 15 years back, and they're still on remission even today. So not per se that they're gonna die.
Yeah.
No, I don't believe that. They make it, and with cancer, you know, it's not only death that comes, there is life.
Okay. Very profound. Now, Prof, she mentioned something about the joys of advancement of, you know, medicine and technology, and through advanced technology, we are able to prolong life. Perhaps let's start by asking you to define to us what brain death actually means, because you often hear people talk about he's been declared brain dead. What does that mean?
Absolutely. And this is where we mentioned the time factor, that you need to start, particularly if the heart stops beating, you need to start compressing. Bystander must start that compression, start the CPR. A defibrillator would be fantastic to get the heart started. But if you can't get the heart started with the initial 3 to 5 minutes, there's insufficient blood flow to the brain, and that's what we call brain death. There's also irreversible death, where if no care is being given, as the minutes go by, eventually the brain function gets worse and the brain stops working. It's all based on time of getting that initial care to the patient and to prevent the brain from dying totally.
Okay. So the brain is dead, but other organs are working, like the heart is continuing to beat.
Absolutely. If you can get the heart to continue to beat, or if the heart is beating, but there's insufficient flow to the brain, that's what we call brain death.
Okay. Now, clearly, this is one subject that sometimes gets a little controversial, that we keep people artificially alive, as it were. Somebody is brain dead, but is on a life support equipment in an ICU in hospital. Take us through what actually happens in a situation like that, and who makes the decision to, first of all, put the patient on life support, and for how long?
In a hospital, it should always be a team-based decision together with the family. And again, based on time, if people didn't start the CPR rapidly, even in the hospital setting, the brain will die. The heart continues to pump, breathing may stop, and they get put on a ventilator. The decision to keep the ventilator going must always be a decision of the medical team, together with the discussion with the family.
Now, sometimes, there's this notion that some people would have put it in their will that should they get, especially people with chronic, let's call them terminal illnesses, would make it very clear that they don't wish to be resuscitated. Should they ever, obviously suffer a heart attack, they should not be resuscitated. They should not be put on life support machines. How often do you get such?
Unfortunately, very few people have living wills, and we actively encourage that, because it's decided by the person while he's in sane mind, able to make decisions for himself, and decides what he wants, what he doesn't want. Does he want to be intubated? Does he want to be on a ventilator? A living will can be anything from 1 paragraph to 10 pages. People can specify what they want. We highly recommend that. Most times the living will actually states if there's no help, please do not provide artificial life support. Now remember, CPR is help, so we do recommend starting CPR, defibrillating, where you can save the patient, unless they specify in the living will that they don't want CPR. But we actively encourage that, because we then know what the patient's wishes are. Sometimes the family's wishes can vary dramatically, particularly in view of the emotion of the person dying in front of you.
Obviously, in a scenario like that, you're talking about somebody who is unconscious, who can't make decisions for himself or herself, and that it's close family that basically that the medical personnel communicate with. Now, is there ever a time where the medical doctors looking after this sort of person says, listen, I think it's not worthwhile prolonging life? Just take us into that sort of discussion you have with family at that time.
Absolutely. There's a big difference between cure and care. Not all patients can be cured, but all patients can be given care. And that's care that must be provided to the patient until they take their last breath or the heartbeat stops. That care, the palliative care that you mentioned earlier on, is absolutely vital. That care is provided by the nurses, the doctors, or the family in their own environment.
Sister, you in the bone marrow unit, and I'm going to come back to you, Prof, about organ donation in that kind of sense. Now, why do people need to go into ICU and high care?
Okay, basically in the unit that I'm working at, we admit them for, we call it neutropenic, where their immune system it's low, so it's more of a protective isolation. We are protecting them because they are prone. With your immune system, when it's low, you are prone to getting other diseases. So it's very vital that we protect you. And remember, they go through already when they are being diagnosed. That also has an impact on their health. It's gonna cause a lot of problems, and then they go through the treatment itself. And the treatment itself, it differs from one patient to another, and some they take it as it comes, but some they go through a lot of emotions, because remember, once one is being diagnosed, there's a lot of stages that has to go through. Even you as a professional nurse that is working there, you need to acknowledge what this person is going through, meaning that there's going to be stages that they're going to go through. Once one is diagnosed with a terminal illness, they go through stages when the way they're going to be in denial, they're going to be in shock, they're going to be angry, why me? They're going to bargain, and then eventually they will accept. And with acceptance, that's where you'll see a lot of progress. But mainly in the bone marrow unit, we're trying to protect them, preserve them, preserve their life, try to eliminate more exposure that could cause harm to them.
Yeah, okay, all right. Well, it seems like it's quite a lot that you guys do there. Hey? Now, Prof, just before we go for a break now, quickly, when somebody is brain dead on a life support, okay, isn't that an opportune time for people like those to donate organs? And what's your advice to families?
Absolutely. In the living will, one can specify that they would like to be an organ donor, which we highly encourage. If it's decided the patient is brain dead, and there are a whole variety of clinical tests that doctors will do as a team to decide that there's absolutely no chance of that brain recovering, organ donation can result in many other lives being saved. So there's an organ donation society, which of course can be called upon and discussed with the family. The treating doctors are often not involved. It's a totally different organization that discusses with the family. But many lives could be saved with organ donation, absolutely.
All right. Okay. Well, thank you so much, Prof. Walter Kluk, Executive Director, Resuscitation Council of South Africa. Thank you for your contribution, and Sister Buhle Mokwena from ICU and High Care Bone Marrow Center at the Garden City Clinic. Thank you very much for your contribution. All right, folks, we're going to go for a quick commercial break. When we come back, we're going to learn more about palliative care. Stay with us. All right, we'll continue our discussion on caring for the dying, and we have two special guests. We still have Dr. Mike Brown, a palliative care doctor from the Wits Hospice, and we're now joined by Sister Frances Hozek. Sister Frances Hozek is a palliative care home nurse based also at the Wits Hospice. Is that correct?
That's right.
All right,
Thank
welcome
you.
to Health Talk, Sister
Thank you.
Hozek.
Good morning.
All right, perhaps let's start with you, Dr. Brown. Now, you mentioned earlier that, obviously giving a description of what palliative care is and so on. Now, yes. I'm informed that there's two levels or two types or two places where this takes place, either inpatient palliative care and home-based palliative care. Just take us through the differences between the two.
Palliative care really is provision of end-of-life care, and that can take place either in the patient's home, and that's most people's preference. International research has shown that 85 to 90% of patients facing end-of-life situation would prefer to die in their own homes. Yeah. We attempt as far as possible at Hospice Wits to maintain people in their own homes, which is where Sister Frances would be involved. Yeah. But sometimes it becomes difficult towards the end, or sometimes there's a preference from the family or from the patient not to die in their home. Mm-hmm. And then we have a facility. We're fortunate enough to have 10 or 11 beds at our inpatient unit facility, where we can admit patients for final end-of-life care for the last days and weeks of their lives.
But how many such facilities exist around the country?
Well, that's the problem really, because and so many of the hospices don't have those facilities. There are a few in the Johannesburg area, probably 3 inpatient unit facilities, and there are a few in some of the other bigger centres, Cape Town and Durban, but in the most part, people don't have that access and would then either die at home, or if they're unfortunate, would land up dying in hospital, which is something we try to avoid, because hospitals are not really designed for patients in the dying process.
Well, talk about hospitals, not being designed for that purpose. Oftentimes you get this, amongst communities that they're not happy with the care that was afforded to their loved ones in hospitals, and in fact, they were discharged in a state that, is not satisfactory to them, and essentially being told that their loved ones must go and die at home. Now, please comment on that, because the perception is that the hospitals are refusing to offer adequate care to their loved ones, and in fact, people are being sent back to their homes to go and die at home.
It is unfortunate because, in fact, in terms of the World Health Organization, to which South Africa is a signatory, patients have the right to being provided with palliative care, the right to die with dignity. Yeah. And as I said before, most hospitals are there for acute patient management, and are not necessarily designed in a way that makes them comfortable places for patients to spend their last days and hours. So patients often are asked to leave the hospital and go to their homes. Surveys in this country and in countries where home situations are often very inadequate have shown that while patients may want to die at home, they recognize the difficulties, and therefore hospital becomes an alternative where there aren't inpatient hospice facilities. But ideally patients shouldn't be in a hospital, should be in their homes or in a hospice facility.
Okay.
I think the difficulty comes is that often these decisions are made very late. And as hospice as an organization, we would really like to be involved in the care of patients from early on in the disease process. Once the decision has been made that it is a terminal illness, the sooner we can get involved, the more we can affect positively the way in which these patients approach their last days, weeks and months of life.
Okay. And of course, Sister Hozak, involving family is another important aspect, isn't that so? You are at the cold face, if I can call it that, because you deal a lot with people at their homes. Take us through what you do.
Well, basically, if a patient wants to be referred to hospice, they have to, first of all, the patient has to give permission. So we never see anybody who doesn't know we're coming. We don't go in as a hospice sister and not tell the truth.
Yeah.
So the patient is referred to hospice by a family member or by the patient themselves. We get a report from the doctor, it's a treating doctor at that stage, which Dr. Brown then looks at. And so we go in and we meet the families. We provide symptom control, we provide counselling, we have a whole team effort. Dr. Brown will visit the patient if we need his backup there. He provides the medicine obviously for us, and then we relate to the families and we visit the families on at least once a week. We call the families. Some patients we see once a week, some patients we see every day. It depends because it changes obviously as the symptoms change and as the patient gets more ill. But sometimes we can have a patient for a long time, and if we find that we're not seeing that patient, the patient maybe goes into remission or the patient doesn't need us, we actually do what we call contract out, with the knowledge that that patient at any time can phone us and we'll go back in. So we're always there as the support for that family and that patient.
And then talk about family. I mean, clearly family has some responsibilities towards this person with a terminal illness, let's put it that way.
Yes.
What are those responsibilities?
Well, I think families want to be involved. I think that's probably the most important thing, is a family wants to be involved, but they don't know how to be. So I think that's where we also come in and we teach them. We teach them the basic nursing skills. We do a lot of counselling with families so that when the time of death approaches, they are prepared for that. We offer nurse aides sometimes who come in and help the families with the nursing. Our counsellor is there for them anytime they need it. So I think the more the family becomes involved, the easier it is for them and also for the patient, because there's a lot of fear around dying to begin with. And I think as time goes on and the more time we spend with that family and that patient, it makes it easier all around. And then it's basically just walking that journey, I think, with the family and the patient. I know you've done it probably for many years. I have.
But is it something that's easy for you personally?
I find for me it's a privilege. It's something I love doing. I love being involved. You know, a lot of people say to us, how can you work with hospice? How do you work with the death and the dying? We're not working, we're working with the living. And it's just that I think we love it because we can provide so much help to those patients and make death actually easier all around.
Easier indeed.
Yes.
Well, thank you so much, Sister Frances Hozak, and I wish you all the best in your work going forward. And let's hope that people continue to live in dignity, because it's about life, isn't that so? Like you said.
Thank you.
Okay, we're going to go for a quick commercial break. When we come back, we'll continue our discussion on death and dying. Please stay with us.
Ephraim defied family and traditions to follow her dream.
Decided that I'm going to prove to them that they were wrong.
The first breakthrough came in when she was studying and touring in Europe.
That was my first breakthrough.
Generations was her first television debut in South Africa.
It was my first gig. I was very excited. I was very happy. I said, yeah, this is confirmation I'm at the right place.
After pain, rejection, and suffering, her dream became a reality.
I followed my path, and I'm happy and grateful and blessed.
Join your host, Puleng Mulabati, on Rupilong every Friday at 17:30.
Hindu devotees took a holy dip at Sangam, the confluence of rivers Ganges. People and priests made their way to the banks before the break of dawn. Security arrangements were in place for police forces patrolling on the river banks to ensure smooth functioning of the event.
A mobile museum in India's West Mumbai is highlighting the skills and creativity of residents of one of Asia's largest slums.
That's what we've been doing here, is creating this platform, and we came here to help it develop and to, just build it up.
Did you go to heaven? Kelvin is the one who created all this. What are you fighting over? Us. If there is 10 million in my account, it will be in the front page the next day. Do you have 10 million? Oh, Jesus, hold my hand. Hallelujah.
It's happening right here on Question Time today. Monday to Thursday at 5:30 p.m. on the SABC News Channel.
To be African is beautiful. To be African is a privilege.
It represents hard work. It represents being able to stand on your own.
And respecting other cultures as well.
It's about promoting African heritage.
We are all Africans. Let's come together so that we can have a formidable force.
Our cultures interlink with one another.
And by standing together and embracing one another, there's power in unity.
It is time to cut off this issue of xenophobia.
I stand for African unity. I stand for promoting unity in Africa because
there are many opportunities
to be whatever you want to be.
Africa is one of the most important continents.
Because if we can come together as one, we will be able to actually build a better Africa, the new Africa for the future. And if we unite our hearts and our minds together and we go forward, we will conquer. So let us all arise and be proudly African.
Being an African is who I am right now.
I'm proudly African. I love Africa.
Wishing you all a very happy Africa Month.
One love.
We are alive, therefore we will die. This is the simplest, most obvious truth of our existence, and yet very few of us really come to terms with it.
For myself, I can't speak for Graham, for myself, I am prepared, not just for my death, that'll be marvellous, but for his death or any other death in the family, I think I'm well enough prepared. If after it happens I need some support, there's plenty of people in this village who know exactly what it's like because they've all been through it.
The goal of care for people who are dying focuses on helping them enjoy as good a quality of life as possible. This may include relieving suffering, helping people stay well as they can.
Once we admit a patient at frail care or even coming into our village as well, we've got a living will. So I think they are prepared because once you get here, you need to already know what's going to happen with me. I'm coming into this village because there is a frail care for me.
What happens when someone starts to die and how end-of-life care is provided.
It's like taking care of your child, taking care of your own grandmother and father and people that you love. So it's all about love and giving the care that they need. I think I'm making a big difference, all of us are, to be with them 24/7 a day. So there's a big difference. And for the families that can't be here, we are here.
Although intellectually we all know that one day we shall die, generally we are so reluctant to think of our death that this knowledge does not touch our hearts, and we live our life as if we were going to be in this world forever.
We don't look into the patient itself. We will focus on the family and relatives around them. But being there for a patient, holding the hand and support them, because you know what, if you haven't been in a situation where you've lost someone, it's difficult to relate to any family member being there at that stage or a nursing staff being there to support this member. And I think the most important thing is to let this patient that's dying, let them know, you know what, it's fine. You did what you did. You can't do more than what you've done. You can let go. You can actually say goodbye.
I do not grieve for people who have lived a full life and who die without pain. The people I grieve for are the young people who get killed in car accidents or all these horrible things that happen to them, or the people here who, poor souls, suffer with some crippling disease. But for somebody just to lie down in their bed and go to sleep and not wake up, I don't grieve for them. God gave us 70 years and 10, and I don't think there's very many people in this village who are under that. So we all on borrowed time, I think.
Welcome back. Now we continue our discussion on caring for the dying or palliative care with our special guest. We still have Dr. Mike Brown, a palliative care doctor from Wits Hospice, and we're joined by another special guest, a palliative care social worker also based at the Wits Hospice, and this is Penelope Mate. Penelope, welcome to Health Talk.
Oh, thank you.
All right.
I'm happy to be here.
Let's start with you. What work do you do?
I'm a social worker. As a social worker in a palliative care context, we offer counseling, and we also do with lots of problems, psychosocial problems, because when the patient is dying, there are lots of issues which are involved there. I will make an example. A lady with a cancer of the cervix, you will find that now she has a problem. Who is going to be left with the children? She might even have a problem that maybe my husband is cheating on me because now of this condition that I have. And there will also be other family problems, extended family problems. Sometimes the patients don't want to disclose to other family members about their condition. So we deal with all of that. And also you'll find that if there is no one who is working in that house, we need to step in as social workers to ensure that the children there are going to school, the family is supported with food, we assist with grants applications. Yeah, we do a lot.
Okay. So I mean, from what I gather from what you say is that you counsel firstly the person that has a terminal illness, the patient, and the family.
Yes.
So what sort of emotional stages or emotional journey does this person go through? Just
the
take us through that.
patient.
Yeah.
You know, with the patient, they find it very difficult sometimes to accept that they are dying. And yeah, it's all about denial, it's all about anger, it's all about bargaining with God. If you can heal me, I will do this for you. And when they come to acceptance, it's better for us, because now we can be able to work
But
with the
do you
patient.
help them get to that
Yes,
stage of acceptance?
we do.
Yeah.
We walk. I usually say we walk with the patient through the journey.
Dr. Brown, I mean, clearly people at that stage also have a right to die in dignity or live in dignity, for the remaining days of their lives, as it were. Now, how do you, as medical professionals, ensure that, they enjoy those rights?
Well, I think really our philosophy is that we promote life. We accept that death is inevitable in the situation where we are involved, but we'd like patients to live their lives as comfortably as they can for as long as they can, and to maintain their dignity. And the major problems that people face towards the end of life are often associated with anxieties, fears, as Penny has mentioned, and then we get to the physical symptoms, and of which pain is often the most important symptom.
Yeah.
And really it is something that we become quite good at managing, because I believe really it is our responsibility to get the patient into as pain-free a condition as possible. And to do so, we use a whole range of medication that's available to us, along with the counseling, because often the pain is associated with psychological pain and anxieties and fears, and that we need to treat differently and other than with just pure medicine. But when it comes to physical pain, we have a whole range of medicines available to us. And we follow the guidelines of the World Health Organization, which is a three-tiered ladder, starting with simple analgesics, moving to slightly more complex semi-opiate type drugs, and finally we land up with the traditional opiates, of which morphine is the sort of major example that everyone is familiar with.
But there are problems there, isn't there? That obviously there's all sorts of abuse of these medications, not by the people that these are intended for, but those around. How do you deal with problems like this?
Well, of course, people are always concerned about morphine and the potential for addiction and the potential for abuse. In palliative medicine, where you're using morphine or its equivalents, and there are a number of equivalents, to treat a patient with severe pain, the potential for addiction is very limited, because the pain and the underlying issues that are being treated with the morphine actually offset that. If you and I were to use morphine as a recreational drug, sure, we'd become addicted. But when you're using it for its intended purpose, that addiction isn't an issue. We do obviously monitor the patient's supplies, and we monitor that they are using them appropriately, because as you've said, there are other people in the family, and there's always some potential for abuse. But we find that not to be an issue. Occasionally we have to be concerned, but in the vast majority of patient situations, the patient is using the medication appropriately. And that's where our home care sisters in the home environment would actually be involved, because they teach, they counsel, they support, and they monitor what's happening in the home environment.
Yeah. The one thing I'd like us to talk about is how medical professionals communicate bad news or news around terminal illnesses with patients. Ever so often you'll hear someone say, well, the doctors have given me 3 months to live, or the doctors have given me 6 months to live. Where does this come from?
That's a very good question, and I wish I knew the answer to that. Virtually every patient, or if not the patient themselves, a member of their family will ask the doctor, how long? How long is this process going to be? How much longer do we have before we die? Yeah. Certainly with patients with chronic conditions, the treating clinician initially who makes the diagnosis and often then refers the patient on to hospice or tells the patient that they can provide no further active care for them, is going to give them some sort of guideline as to what the time process may be. And that's generally based on some form of statistics, some form of medical outcomes, reports, and it's an average.
Yeah.
But if you imagine for a patient, this is a Gaussian curve, and they could be on one end of the spectrum or on the other end, so it really is an average. And very often those predictions are wrong. And I try not to answer that question because I don't believe we know.
Isn't this about probability of dying within a specified period of time? Not that somebody is going to die within 6 months or 3 months or so.
None of us has that knowledge. We honestly don't have and we don't. I don't think we as human beings are well structured to be able to cope with that knowledge.
Okay.
So I don't answer that question if I can avoid it.
Your final words, Penelope?
I will always say, when it comes to counseling patients who have terminal illness, once off counseling is not enough. Because like you're saying, on diagnosis, when you tell the patient that they have this type of a disease, as a social worker, in my experience, they don't register it in their minds. So you need to go to them over and over and over again until they understand what is really happening with them. Yes.
All right.
Yeah,
so people listening or watching this program, I mean, where can they get help? You know, where can they have access to people like yourselves?
If they want to have access to palliative care services, they can contact us at Hospice Vets. The number they...
All right, we'll put the number on the screen. Unfortunately, we've run out of time. Dr. Mike Brown, Sister Penelope Mati, both from Vets Hospice, palliative care doctor, palliative care social worker. Thank you very much for your contribution. Okay, that's where we're going to leave it today. And remember that you can join us again next week, SABC News. A reminder to please share your views and comments with us on our Facebook page, SABC Health Talk, and follow us on Twitter at SABC Health Talk. Remember also that you can watch a repeat of this show today at 2 p.m. and on Thursday morning at 5 a.m. I'm Dr. Selva Matang. Thank you so much for watching, and please do take care.